All right. The House Committee on Human Services will now come to order. The clerk will call the roll.
Chair Frank,
Here.
Vice Chair Rose,
Here.
Representative Click, Representative Shaheen, Representative Ramos, Representative Noble,
Here.
Representative Campos, Representative Hull, Representative Manuel.
A quorum is present. Members, today we're going to take up pending business and hear new bills and take public testimony. As I mentioned to most of y'all when we come in, we're going to vote on bills when we come back from the House floor. Had a couple committee members that were here very late, a couple of others, including Representative Noble, that are fixing to go lay out bill in another committee. And so we're going to vote on bills later today, or when we come back. Reminder of those in the audience wishing to testify on the bills listed on the agenda, you do need to fill out a witness affirmation form, please. Do that at the registration kiosk outside the hearing room, or if you need assistance, you can come up and talk to our very able assistant clerk, Blake Albright, to help with the registration. You can also speak to him if you require a translator or have any disability for which you need assistance. If you've already registered and you wish to change your position, please let us know when you're called to speak, or again, see Blake. Please don't register twice. Don't be that person. Today is the testimony will be limited to 3 minutes. There is a timer right up here. When the light turns yellow, you have 30 seconds remaining. When the light turns red, please wrap it up, and members may ask questions. If you have any handouts you wish to distribute, please also give them to the assistant clerk at the desk, and he'll distribute it to the members. Members, any questions, comments? All right, seeing none, we will begin. The chair lays out House Bill 940 and recognizes Representative Dutton, Chairman Dutton, to explain his bill. We represent his staff to run get him. What's that? You gotta have fun. It's early. The chair recognizes Chairman Dutton to explain House Bill 940.
Thank you, Mr. Chairman. Thank you for the.
We're voting later. That may have surprised
thank
you.
you for the coffee too. I appreciate you all hearing this bill. And one of the things that I did during the interim was I talked to a number of parents in my district, and listening particularly to the single parents. One of the biggest issues they had was child care. And when we talked about it, and more we talked about it, most of them had the same problem. The availability of child care and the affordability of child care. They simply couldn't either afford it or it wasn't available. And I wondered, what could this legislature do about that? And I wasn't sure. I had several answers, and we started to file those answers as bills, but I thought that may not get at the problem, because too often, sometimes here in the legislature, we develop a solution for something that has nothing to do with the problem. And so we think the problem's intractable because we have assumed that the solution we gave was the solution to the problem. I don't know what the answer is here. But what I did is, in doing that, developing an answer, I thought one of the things that you all might do and the legislature might do is at least study this issue to bring some clarity to it in terms of what we ought to do. And so what I've done is propose to add members of the Senate and the House so that they could collectively come together and kind of make some determination about what the problem is first and what the solutions ought to be. And that's essentially all this bill does.
Yep. All right, thank you. Members, any questions? All right, thank you very much. We do show people, we don't have anybody wishing to testify. At this time, there are no witnesses signed up to testify. Is there anyone else wishing to testify on, for, or against House Bill 940? Seeing none, public testimony is now closed, and the chair recognizes Representative Dutton to close on House Bill 940.
Thank you, Mr. Chairman and members. You know, the stats indicate that sometimes a household will spend 25% of their income towards child care. That's extremely high, considering what child care costs now In Houston, for example, the average cost for a preschool age child was $944 a month. In San Antonio, it was $815 a month.
Yeah.
That's one child. In Fort Worth, it's $933 a month. In Dallas, it's more than $1,000 a month.
Right.
And so I leave it with this committee to kind of decide what we ought to do about that.
And Chairman Dutton, I did want to discuss it because I think it's a really worthy thing because you've got one governor appointee and you have 3 members of the House and 3 members. These are
Yes.
actual members.
Right.
Do you see them coming up with a written document?
Well, I
Or
hope they'll
just
do what I
studying the
said
issue?
earlier, that they'll explore the issue to determine exactly what the problem is, and then offer solutions to that problem. And so I would hope they would come back to this legislature with a written document that says what this legislature ought to pursue in terms of trying to deal with this.
Okay. Thank you. Members, any other questions? And the chair recognizes Representative Manuel is present. Members, any questions, Chairman? All right, thank you very much. If there's no objection, House Bill 940 will be left pending. Is there objection? The chair hears none, and House Bill 940 is left pending without objection. Gotten off to an amazing start. The chair lays out House Bill 1879 and recognizes Chair Darby to explain his bill. Representative Darby, I understand you do intend to make some changes. We don't have the committee sub in front of us, but certainly
I'll speak to some of that.
speak to any of them. So.
Okay. Well, thank you, Chairman and Vice Chair, members of the committee. It's my privilege to offer House Bill 1879, which seeks to address our ongoing mental health workforce shortage. The mental health workforce is not meeting the critical demand for essential mental health services here in Texas, and especially in rural Texas. This session, we're working hard to invest in new mental health facilities, but we need to ensure that we have the personnel to staff these facilities. House Bill 1879 is a constituent-driven issue for me. I was approached by several of my local providers who are facing severe staffing crisis for rural workforce. You will hear from one later today. House Bill 1879 seeks to allow licensed master social workers and licensed professional counselor associates under clinical supervision to be reimbursed through Medicaid while completing their clinical training to incentivize graduates to become clinicians. LCSWs and LPCs can bill Medicaid for psychotherapy services. LMSWs and LPC, I don't know, all these initials are.
Oh, we are actually the official acronym committee of the
Okay.
Texas House.
Goodness
So
gracious.
we have more
Anyway,
acronyms
they're
than any
working
other
for a
committee.
license, but
Right.
they have to, it takes 3,000 hours as an LPC associate in 2 years to become a licensed professional counselor. So as introduced, House Bill 1879 seeks to allow LMSWs and LPC associates under supervision to be reimbursed at a rate equal to 70% of the reimbursement rate for licensed psychiatrists or licensed psychologists while providing similar services. In a committee substitute that is being drafted, we plan to have a few changes, including licensed marriage and family therapist associates in the bill, in the eligible billable providers, dropping the rate from 70% to 50%, including language that ensures the federally qualified health centers, FQHCs, are reimbursed for services provided. And we're still working with numerous stakeholders to provide social works and psychologists on various concepts. Members, 80% of counties in Texas are designated as mental health professional shortages areas. 159 counties in Texas have no LCSWs who accept Medicaid. I served on the Youth Health and Safety Select Committee, as did Chairman Frank and Vice Chair Rose. I mean, one of the many issues that we tried to address and should address involved, and I will quote to you part 2 of our report, which says, establishing billing parity between providers offering similar services by expanding the pool of provider types that are allowed to bill Medicaid for mental health services. This bill does exactly that. So we have a unique opportunity this session. I think we need to seize this opportunity and provide for these much-needed services all across Texas and certainly in rural Texas. With that, I'll stand ready for questions if anybody has any.
Yeah, members, any questions? Okay, I just had
Sure.
one. The tagging, not tagging, the tying the rates, 70%, 50%, where did that come from? Is that best practice? Because I don't think that's the way, and we have a resource witness on almost every bill. I don't know if there's a resource witness on this one, but I'm curious, that's not how it's done for almost everything else. I'm curious where that came from.
I think it's an opportunity to provide an established rate, clearly the Medicaid rate, but prescribe a level of reimbursement. What is appropriate? We first introduced 70%.
Right.
That was appropriate. There has been some pushback against that level of funding.
Okay,
So
and I misunderstood. So on the comment, you changed everything from 70 to 50. I thought you added a new class.
we added another licensee.
Okay, so you added another licensee, but then the 70% went to 50% for all of them.
For all of them.
Okay,
That's
sorry,
correct. I'm
I just
not
misunderstood what you were talking
distinguishing
about.
between licenses.
Okay,
That's all going to be reimbursed at 50%.
okay, very good. Members, any questions? You do have some witnesses, and I assume you'd like to close? All right, Chair calls John Austin Stokes with the West Texas Counseling and Guidance Center for the bill, and then Kathy Ryder is on deck.
Good morning, members.
And we show you as John Austin Stokes with West Texas Counseling and Guidance Center for the bill. Is that correct?
Yes, sir.
All right, thank you. Go ahead.
Thank you, Mr. Chair. My name is John Austin Stokes. I'm on the board of the West Texas Counseling and Guidance Center. Been on that board for about 6 years. I wanted to talk to you a little bit about kind of what cognitive behavioral therapy is. I think everyone's becoming more and more aware of that, but for me, it took me a long time to get it. I've been on that board for a number of years, and I've listened to a lot of clinicians and a lot of experts talk about it, but I needed to kind of dumb down to a West Texas level for me.
Hey, no talking bad about West Texans here.
Sorry, Chair. So,
Don't you train your... Sorry, go ahead. I'm sorry, go ahead.
So basically what CBT does is it makes people aware of kind of things that are floating around in their subconscious. We're all products of our environment, and we all live lives, and we all go through a lot of things, and some of those things are bad, and some of those things get stuck in your crawl. There's my West Texas coming out, Mr. Chair. And what it sometimes does is when that stuff's still floating around in there and you pull up behind somebody and they're waiting too long at a red light and they're not going, you'll honk your horn instinctively. Well, you're not really mad at that person. You're mad at life. What CBT has done for me personally is allowed me to understand that life is not in front of me in that car, and allows me to be present. And you work through that during counseling. And so I think that it's something that's beneficial to everybody. In West Texas, we like to claim that we have the bootstraps mentality, and that we all are self-propelled and we can all fix things on our own. I think it's probably not fair to claim that as West Texas. I think that's probably a Texas sentiment. I think we all do that. We're all tough. We're all raised to be tough. And that keeps a lot of people out of counseling. But unfortunately, that also kills a lot of people because our suicide rates, especially in West Texas, are among the highest in the country. So getting people to understand that therapy was not something that anybody needed to be afraid of was a big thing in San Angelo for us. And Dusty and his group has done a fantastic job of that. And I think he'll talk about the numbers here in a minute. But a lot of the way we did that was through word of mouth. People knew that other people's marriages were in trouble and they went to therapy and it helped, or that other people's life circumstances were really getting them down and they went to therapy and they got some help and they saw some positive results. And as a result, we have broken the stigma in San Angelo. And so there's not many people you can talk to that won't say that they're not open to therapy, or they're not aware of somebody that goes to therapy. And it's driven our need through the roof, frankly. And lastly, second to last, I just wanted to mention, I'm also in my spare time the executive director of the Concho Valley Council of Governments. I'm not here on their behalf. I'm here on the board's behalf. But I did want to mention that a couple years ago, before COVID, we could identify that about 100 of our 300 employees were struggling with something. We didn't always know what. We knew they were struggling with something. Post-COVID, that number is closer to 200. And I think that's a good sample of the general population. And lastly, just personally, I'm a product of CBT. I stand here before you today. 9 months ago, I was kind of a self-imposed crisis, and I got some help, and I'm here with a full heart before you asking for this on behalf of everybody. Thank you.
Thank you very much. Can I ask just a quick question?
Yes,
Thank
sir.
you for your testimony. The training levels, can you explain the training level difference between the group of providers that we're talking about now and a fully licensed?
I'm going to let Dusty answer that.
Okay. Thank you.
Yeah, I think that'd be better.
Okay, thank you. Members, any other questions? All right, thank you for your testimony, sir. Chair calls Kathy Ryder, testifying on behalf of herself and the Texas Society of Clinical Social Work on the bill. That's the way we have you listed, as Kathy Ryder, Texas Society of for Clinical Social Work on the bill. Is that correct?
Yes, sir.
All right, thank you.
Good morning, Mr.
And
Chairman.
and yourself, sorry.
Yes.
Yeah,
Good
okay.
morning, Mr. Chairman and members of the committee. I'm Kathy Ryder. I'm an LCSW, which is a licensed clinical social worker. I've practiced in Texas for over 50 years doing outpatient mental health. Medicaid is a program that addresses one of our most vulnerable populations. They are complicated cases. They are very difficult. If we have a shortage of providers across the state. You're going to hear several people speak to that. I think it's important that we expand the provider pool, and then we also provide supervision. Now, social workers, LMSWs, who are licensed master social workers, do have clinical training, 2 years of field practicum where they are working in agencies and hospitals and schools. It's also important that they have supervision to deal with these complex issues. Part of the issue is not only the shortage of mental health providers in the state, but when you have low reimbursement rates, which is where we are in Medicaid program, then seasoned providers who have established their practices or agencies who are, overwhelmed with need, as the earlier gentleman testified to. When you have low reimbursement and you're just going to be less likely to take these complicated cases. So we would urge the committee to support this bill and support the extension of providers, as well as parity across all of the providers in terms of reimbursement.
Okay, are you done?
Sure.
Okay, thank you. So we have you registered on the bill, but then you ask us to support the bill. Are you on the bill, or are you supportive of the bill?
Well, we are aware that Representative Darby and his office is working on a committee substitute, and
Okay,
so
so you are
we're-
on the bill or neutral as it stands
as it
today?
stands right now, and
but you have
we'll
been,
be in support of the substitute, yes. Research shows that talking therapy, better known as psychotherapy, is very effective in helping families deal with all the stress, and as others have talked about, it is difficult to manage when you're a single parent and you have children and they're having issues in school and trying to get child care as well as put food on the table. So it's important, I think, for this bill. It addresses expanding the providers as well as parity across reimbursement.
okay.
And I'm open for questions.
And can you speak to the question asked earlier about the level of training for
Sure.
current licensees versus
Sure.
those pursuing? When would it start? Because it seems to me it would start fairly early. If you would speak to that.
Sure. I can speak to social work. I think others are here that can speak to the other mental health professionals. Social work is a 2-year graduate program, which is schools that are accredited by a national accrediting body. They have 2 field practicums of 40 hours a week for 6 months each, and they are under clinical supervision, and they've chosen that particular specialty area called interpersonal helping, and they are taught how to interact with folks, how to do a variety of modalities in terms of psychotherapy, and to also be able to access resources for the families or the individuals that they are seeing. Clinical social workers are individuals who not only have their masters in social work, but have also done an additional 33,000 hours of clinical supervision with additional folks, and then have taken a national exam to be licensed as a LCSW.
Okay. And I'm trying to remember, and I don't know whether you've seen it. is the person working under a licensed, in the bill, are they working under a licensed, under their supervision?
Under 1879, LMSWs would be under clinical supervision of LCSWs to help them navigate.
And then last but not least, since you had talked about, y'all were concerned at this rate, less concerned at this rate, most of the, or all the rates in Medicaid are left essentially to the department to come up with.
Right.
Should they be pegged as a hard peg, or should that float like every other rate, or should it float with the master's level license?
Well, I think that we in the mental health profession would like for us to have pay parity, that across the board. When you're doing psychotherapy, when everybody's delivering the same services, then that reimbursement rate should be the same across the board.
Okay, thank you very much.
Thank you, sir.
Any members, any other questions?
I'm sorry.
No, that's good. Thank you very much for your testimony. Chair calls Mickey Hand, Texas Association of Community Health Centers and Frontera Health for the bill. Did I get any of that right? I've got you.
Yeah.
Why don't you state your name, who you're with, and go ahead.
So Mickey Hand, I'm representing the Texas Association of Community Health Centers and also Frontera Healthcare
Okay. And you are, your position on the bill?
for it.
For the bill. Okay,
Yes.
thank you.
Yes. So the State Association and Frontera Healthcare Network strongly support House Bill 1879 because health centers have seen a growing demand for behavioral health services across the state and struggle to find and recruit the workforce needed to meet the rising demand. House Bill 1879 will help to immediately alleviate workforce challenges by allowing licensed master social workers and licensed professional counselor associates to get reimbursed for services they are often already providing. This will help us be sustainable, meet increasing need, and grow our own workforce trained to serve our unique population. Texas Association of Community Health Centers serve 1.7 million Texans across the state, and we are in 137 counties. At Frontera, we serve Mason, Menard, McCullough, and Brady. I think you guys heard Representative Darby talk about how this really impacts rural counties. We're an example of one of those rural counties. There is such a growing need, especially amongst our at-risk youth in these counties, and there are no LPCA or LPCs or LMS or LCSWs to hire, the fully licensed ones. There's none of those to hire. However, we are able to grow our own. We've been able to support those going back to school to get their master's. We've been able to support some LPCAs and LMSWs through grant dollars, but grants only go so far. And so currently right now, our health center has a grant that's supporting 2 LPCAs, but we still have such a need. Right now in the counties that we serve, we have 3 ISDs that have asked us to go open school-based clinics with a sole focus on mental health because they are having such a need, especially amongst the elementary age. We have been asked by 2 county jails to go and rotate and do behavioral health services in there with the hopes that they will not have repeat offenders if those that are incarcerated get the services that they need. And then also I have a county judge who has approached us and asked us to partner to come up with a behavioral health program that he can refer juveniles to in conjunction with community service, probation, those types of things, in hopes to get them the help that they need so that they can be functioning adults in society and make good decisions. We strongly support this bill and think it will immediately increase access to behavioral health services across the state and will help us on the primary and preventative level of behavioral health care, which I think in long term will save us funds down the road.
Okay, thank you very much. Members, any questions? Thank you very much for your testimony. Chair calls Jan Freese, Texas Counseling Association, on the bill. And then Brian Mares is on deck. Did I get that right, Jan Freese?
Almost.
All right, why don't you
Freeze,
say
like
your name,
cold.
who you're with?
My name is Jan Freese. I'm the CEO of the Texas Counseling Association. I'm testifying today on House Bill 1879. We're testifying on the bill because we were working with the sponsor on the committee substitute.
Okay.
TCA represents over 7,500 professional counselors working in an array of settings across the state. I thought I'd jump in and give you the credentials for LPCs. So a licensed professional counselor holds either a 60-hour master's degree or a doctorate degree, passes rigorous licensing exams, and completes 3,000 hours of supervision. An LPC associate holds, again, 60-hour master's or doctorate degree, has already passed all of their licensing exams, and is participating in 3,000 hours of postgraduate supervision. This postgraduate supervision is where those associates, they actually see their clients independently and only meet with their supervisor a couple of days a week. So it's not like a practicum. There's really a lot of independent practice that goes on there. As you've heard, we really need a robust mental health workforce here in Texas. We have almost more than 4 million Texans have been diagnosed with serious mental illness. Less than 35% of them actually receive treatment. In our counties, the LPCs are the largest group of clinical mental health providers in the state of Texas. The challenge that we are seeing with them in terms, only 20% of them, those will accept Medicaid because they are reimbursed at only 70% of the rate that a psychologist and a psychiatrist receives for the same services. So we are working with the sponsor to try to get parity here so we can get more LPCs able to accept Medicaid. The primary reason that they say they don't, is because they can't make a living wage. They cannot support and sustain their practice. So we are also very supportive. We've been working for several sessions now in an effort to try to also get our LPC associates and LMSW associates working under supervision to be admitted to Medicaid. We do see this as feeding the pipeline because just as in law, right? You graduate from law school, generally speaking, the area of practice where your first job is going to be your area of practice for life. If we can get these people who are under clinical supervision working with this population, the probability of them continuing to remain in the workforce and serve that population is extraordinarily high. This, if there ever was a session for us to do it, this is the session to do it. So we really would appreciate your support to help us address that unmet need.
Okay, thank you very much. And I'm going to just clarify, just to make sure you're on the bill.
I am
the support
I
is
am
more some
on
of the
the
things we're
bill,
talking about. I
supporting the
just-
changes in negotiation with
just wanted to
Representative
get-
Darby. Thank you.
Yep.
Thank you, sir.
I'm actually going to call resource witness real quickly. I'd like to call Ryan, or Dr. Ryan Van Ramsort from HHSC on the bill.
Good morning. Ryan Van Ramshorst, Chief Medical Director, Medicaid CHIP Services. Here is a resource on the bill.
Okay, thank you very much. Just a couple questions on the
Sure.
reimbursement. How did the reimbursement get set for the licensed person first?
So right now, I'll walk through kind of the tiers of payment that we have in policy. So psychologists are considered kind of the highest level of training. They're paid at 100%. The next step down at
What is that reimbursement? Do you know that?
I don't have the rate off
Okay,
the top
that's
of my
fine.
head.
But it's 100%, okay.
Yeah, we'll say it's 100%. The next tier down would be our other fully licensed professionals, licensed clinical social workers, licensed marriage and family therapists, and licensed professional counselors. They are paid at 70% of the psychologist rate. The next tier down are what I would consider to be trainee level or staff that need supervision. We have postdoctoral psychology fellows and predoctoral psychology interns that are paid at 50%. So that's kind of the way that it's tiered right now.
Okay, thank you very much. And how is the, and if you would provide us that number at some.
We can get that
at some
to you.
point, but how is that number determined?
So that would be based on the process that our provider finance team goes through to determine rates for our fee-for-service program. And I think, as was stated earlier, the managed care organizations do have flexibility to adjust those rates to meet the needs of the population they serve.
Okay, and so, but when they managed care, because most of ours are obviously provided through managed care, I'm trying to figure out, because I mean, the concept of what we're doing, I like also whether it will fit within the fee-for-service or managed care, if this will create problems in the way we're doing it, to index it, or do we need to have more flexibility with the same concept?
What I can say is many of the MCOs do use that fee-for-service rate as a base or a foundation of sorts, and then would have the ability to pay above that. And so an MCO would have an opportunity to adjust where that 100% for the psychologist is, and then tier the rate according to our policy.
Okay, thank you. Members, any other questions? All right, thank you very much thank you for jumping in on that. Chair calls Brian Mares, National Association of Social Workers, on the bill. And that's how we have you listed. Did I get that right?
Yes, you did.
Brian Mares, National Association of Social Workers, on the bill.
Yes, appreciate you pronouncing it correctly. I often get mispronounced.
Stumble into it every once in a while.
Good morning, committee members, Chair Frank. My name is Brian Modis, and I serve as the Government Relations Director at the National Association of Social Workers, and I'm here to testify on the bill, much like was shared by a colleague of ours earlier, that we're working with the author to work on that substitute language that includes that pay parity component. I'm sure that all of you are very familiar with it. We're headed towards a deeper crisis when it comes to the mental health workforce shortage in Texas. And the Behavioral Health Executive Committee has said in a Texas Tribune article last month that we aren't producing enough graduates to replace the workforce that is leaving due to either retirement or experiencing burnout. And just yesterday, BHEC released data from their workforce survey confirming that the majority of actively licensed mental health providers do not accept Medicaid as it is. That being said, just for reference, what those rates are, I've provided in that handout to you all. To answer that question of yours, Chair Frank, so psychologists and psychiatrists billing at the 100%, it's $116 to $122. It just depends if they're serving youth or adults. And then for the other providers, licensed clinical social workers, LPCs, LMFTs, those are, the reimbursement rate is at 70% for $81.20 to $85 approximately. So even at 50% for the associate level folks, we're looking at $60 approximately.
And so are those the rates? That's the Medicaid reimbursement rate.
For psychotherapy and Medicaid, yes.
And so those are the rates that people can't make a living on?
Allegedly.
Okay. 81. Okay. Thank you.
Yeah,
Thank
absolutely.
you for providing that.
Yeah, absolutely. And on the back, I know that there were a lot of acronyms there that Representative Darby was trying to get out to y'all. So if we lose you at any point, on the back of the page, all those categories of providers are listed out, along with how many of those providers are registered in the Medicaid network. This is data that we received from the agency in November of last year. You'll see that the majority of them are your LPCs and LCSWs. I think that also just on top of those rates being low, one of the issues is that we're creating this financial barrier for folks that want to pursue their clinical licenses, since it costs anywhere from $3,000 to $5,000 to pay for the supervision period. So that creates less incentive to pursue this work. And just for reference on there as well, we have data from BHEC that says that approximately 1,500 LMSWs, so your licensed master's level social workers, are under supervision for clinical licensure every year, all of whom would potentially be eligible for something like this. Now that y'all have a little more information on the rates and all that, really hope that y'all will provide some direction at the agency on increasing these rates through parity and ensuring all mental health professions are reimbursed at the equal rate for the same billing code, while also trying to focus on expanding the mental health workforce in Medicaid by allowing those that are already trained, licensed to provide these services while being supervised at the same time. Thank you so much, and happy to answer any questions.
All right. Thanks, members. Any questions? All right. Thank you for your testimony. The chair recognizes Representative Hull is present and coming in from another committee. She's not. So the final witness I show, chair calls Dusty McCoy, registered for testifying for self and for the bill. And show nobody else wishing to testify, so if you want to testify, please get registered.
Hi, thank you.
Did I get that right? Dusty McCoy, self for the bill?
Yes, West Texas Counseling and Guidance. I'm the CEO.
Okay, are you testifying on their behalf?
Yes.
Okay, so we need to get that changed. You can change it? Okay, go ahead.
Great. I'm the CEO of West Texas Counseling and Guidance. We're a nonprofit counseling center in San Angelo, Texas, but we serve many of the rural areas. We have Ozona, Sonora, Junction, Mason, Menard, Big Spring, Big Lake, and Del Rio, and also Uvalde. we have a real shortage, as everybody has said, and it's, I believe, even worse in rural West Texas. We have 500 people on our waiting list right now, and that is just I mean, we just cannot get enough providers to get everybody seen. So one thing that kind of stands out about this was we did go to Uvalde the day after the shooting there, and the FQHC there had built out in 2009 a whole behavioral health unit, a very nice unit, and it just remained vacant until the day after the shooting, till we got there. They cannot and couldn't get providers in that area. This here is a very simple solution to a very complex problem. It's at least a step in the right direction. We do have our suicide rates are high all over West Texas. It's just a huge problem for us. One thing that this would also do is, if y'all make the change here with Medicaid, typically the private insurances follow suit. So it's not only a Medicaid, this will not just help Medicaid folks, it's going to help everybody. I also, if you look at the physicians, how that works, when they go to residency, could you imagine if they couldn't bill Medicaid for 2 years, what kind of disruption that would be? How that would affect the pipeline there for physicians. This is basically the same thing. I have 500 people on the wait list. I got a LPC associate that's working as a case manager now that can't do therapy because we don't have the funds to pay her. And then there's also, I know of another LMSW that we could hire tomorrow if we had this change. Anything that we can do to increase the provider pool is what needs to happen. And so I am 100% in support of this. I'm 100% in support of anything that adds providers so we can help our people. And I'll take any questions.
All right, very good. Thank you very much for your testimony. Members, any questions? All right, thank you again for your testimony. At this time, there are no other witnesses signed up to testify. Correct. Is there anyone else wish to testify on, for, or against House Bill 1879? Seeing none, public testimony is closed, and the chair recognizes Chair Darby to close on House Bill 1879.
Thank you, Mr. Chairman. Members, clearly there's a need. I'm kind of tired of studying this. I've been on a lot of committees that we've looked at this issue. Clearly the need is there. We need to address it. Now is the time. And I challenge each one of us, myself included, that we need to stay the course and we need to fix this. I mean, it doesn't do any good to keep giving the same response to this problem over the years and we don't have the resources. We have the resources. We have the resources this session to do what needs to be done. I challenge each one of us to fulfill that obligation. So with that, absent any questions, Mr. Chairman, I will close.
All right, very good. Thank you, sir. If there is no objection, House Bill 1879 to be left pending. Is there objection? The chair has none. House Bill 1879 is left pending without objection. Chair lays out House Bill 1571 and recognizes Representative Lozano to explain his bill. And I understand you have some changes. We don't have a substitute in front of us, but you're welcome to tell us what you're looking at.
Thank you. Thank you, Chairman Frank and members, for the opportunity to lay out House Bill 1571. This bill is a result of our work in the Youth Health and Safety Committee, the last interim. One of the themes that we heard during those hearings from parents, teachers, and mental health professionals is that many kids are presenting in schools with behavioral and mental health needs. This is especially seen amongst our youth who interact with the juvenile justice system, foster care system, and that have other family challenges. House Bill 1571 utilizes the School Health and Related Services Program, SHARS, to obtain federal reimbursement for behavioral health services provided to all Medicaid-eligible students. Currently, reimbursement can only be provided for Medicaid-eligible students with an individual learning plan. This bill does not expand Medicaid. It just allows schools to be reimbursed for mental health services for kids who are already enrolled in the program. The bill also gives strong protections to parents and families by requiring written consent from parents before any services are provided and permits the parents to stop the services at any time. It also requires the provider to provide a written summary to the child's parents and primary care provider after each service visit. My intent is to have a committee substitute. It was not ready, but the substitute fixes some errors in the draft and reiterates the narrow scope of this bill and ensures parental rights. There are several expert witnesses here today to discuss how covering these services under SHARS might work. Mr. Chairman, I'm ready for questions or reserve my right to close.
All right. Members, any questions? All right, and you will certainly have that. You do have a number, there's 6 witnesses that I show and a whole lot of people that have dropped cards. So Chair calls Linda Litzinger. Is Linda here? And then Amy Litzinger is on deck. And I show you as Linda Litzinger testifying on behalf of self and Texas Parent to Parent for the bill. Is that correct?
Thank you. Yes, thank you. I'm going to get closer to it. Hi, Chairman, thank you, Chairman Frank and Vice Chair Rose and committee. I am representing Texas Parent to Parent. We are an organization serving 14,000 families who have children with disabilities and mental health issues or chronic medical needs. And we are for this bill. It is really wonderful when you can get some of the medical things you need at your school. Many of our children have already been getting those things through therapists, assistive technology, and paraprofessionals, and nursing care at school. So we are glad that we're adding mental health services. We do have an experience of parents not seeing explanation of billing from TMHP and finding on their private insurance that they were billed. Now, private insurance is supposed to be able to see that it happened in a school and that then they can turn it down if it happened in a school. But we are seeing parents having things hit their billing in private insurance that has that doesn't even match who their child is and what their child's needs are. And it has been things like an entire paraprofessional salary and benefits or durable medical equipment that the school can't produce. So we ask that if you add anything to this bill, that the parents get to review the explanation of benefits. That will help on the acute care side. The children who have private insurance only got Medicaid because they're nursing or institutional eligible, and they got MDCP, DBMD, class, HCS, something like that. So they have this wonderful private insurance, and HIP may be paying for it. For example, we had AT&T insurance and we had military insurance, and it paid 100% of everything so that you didn't have to stress the market finding subspecialists that take Medicaid. You can keep all these good subspecialists that only take private and keep them with the families that have private insurance. And so don't stress that. Don't stress the cap that these kids have. Just give the parents an explanation of benefit, and then everything works beautifully. It becomes a well-oiled machine. The school provides it. The private insurance says, no, thank you, we're not paying it, because SHARS billing will continue to pay it. And then the private insurance pays all this wonderful acute stuff that you need those doctors to pay for because they're not taking Medicaid. Am I making sense? I'm sorry.
Yes, ma'am.
Okay.
All right. Members, thank you for your testimony. Members, any questions? Okay, thank you very much.
Okay.
Chair calls Amy Litzinger.
Will you set it for her? Okay.
Good morning, Chairman Frank and committee. My name is Amy Litzinger, and I'm from Austin, Texas. I'm representing myself today, and I am for the bill.
Awesome.
I'm coming today to show you what it's like to need this SHARS billing, but also to need it to be accurate and ethical. I needed a lot from my school in terms of durable medical equipment. I had a full-time paraprofessional. I had a lot of therapies and a lot of assistive technology. All of those things are great when provided by this SHARS billing, but if it's not done ethically and the goal is to make as much money as possible for these billing companies that will bill SHARS and ask the schools for a percentage, that percentage of profit, if billed incorrectly, might get to your cost cap if they're billing for as much as they can. And if you get to your cost cap because you need it and you got your services, that's one thing. But getting to your cost cap on Medicaid because your Medicaid number was used to support other kids that may not have even gotten what they needed, that's scary as a self advocate, especially since if it was done while you were in school, you may not have even seen the information that affected you long term because maybe not even your parents had informed consent, let alone you. So those were the two things that I wanted to say, that it works when used correctly, but when used incorrectly, scary things might happen. Okay. Do y'all have any questions? Thank you for your time.
Thank you for your time and for your testimony. You did a great job. Thank you. Chair calls Sarah, I'm sorry, members, any questions? Sorry. Chair calls Sarah Broom. So is registered for self and for the bill. And then I've got Sarah Podrati on deck. Okay. Did I get that right? Sarah Broom, self, for the bill?
Absolutely.
All right, thank you.
All right. Thank you. Good morning, members. My name is Sarah Broom. I am one of your neighbors over in Louisiana. I have run a school there for a little over a decade, and my school used Medicaid successfully to provide behavioral health services to students, and it was a game changer for everything that we did. I had 180 students at my school, very high needs kids. And before we implemented our behavioral health program, we were going to the emergency room 30 times a semester for suicide risk assessment, COPE team, self-harm assessment, things like that. After I implemented my behavioral health program, we went once the first semester, and then we stopped having to go. Because getting behavioral health services to kids in their school setting helps get in front of all of the major problems that are coming up. But I'm a school person, and I had to figure out how to put this in my budget. And to figure out how to pay for this, I was able to use school-based Medicaid, which is what we call it in Louisiana. It's SHARS here. I was able to use this because Louisiana had expanded our Medicaid services to include kids that didn't have IEPs, so exactly what this bill is talking about doing. That allowed me to bill for all the students I was providing services to. So I was able to provide 2 full-time social workers, 4 part-time social workers, and 2 nurses, and Medicaid paid for the vast majority of those services. And it's the only reason I was able to provide them at my school. But it was an incredible challenge. I can't emphasize enough that I am a teacher and an educator and not a healthcare professional. And all of a sudden, I was in the world of medical billing, and I had to act like a hospital, and I had to learn what a CPT code was, and it was incredibly confusing. And so all the time that I spent doing that was frustrating because I saw this as the biggest pathway to funding mental health services. And so I worked with my state in Louisiana to create better resources for our schools to teach them how to do that so that exactly the mistakes that were just mentioned didn't happen, because those can't happen. This is people's health insurance and we have to protect it. I am such an advocate for this bill and for this program because school-based Medicaid, your SHARS program, this is the single largest sustainable funding source for mental health in schools that exists, period. And it does not cost your state anything to do it. All we are doing is taking your existing state education dollars and leveraging them to pull down additional federal funds to pay for these health services in schools. And if that sounds like a fairy tale, I will tell you it is challenging, and there should be no blind side about that. We should all go into this eyes wide open. This is a really hard program to run because you are asking me, you are asking schools to be healthcare professionals. But with the right collaboration and the right support between the Medicaid agency and the state education agency to provide materials for us and to teach us schools how to do this, we can absolutely do it. And we can provide these services to kids. There's never been a moment like right now to do this work. One, because we have seen the intense mental health crisis we're all in, but also because the federal government has recognized it. And the Bipartisan Safer Communities Act, 1, authorized CMS to provide additional guidance to states, and that's coming out by June 30th. And 2, authorized them to provide $50 million in grants to states to do exactly this, to write the professional development and training that you need to support schools and to put everything in place that you need for this program to be a success. This is the moment to do this right now, today. If you wait a year, you will not have the same resources to implement this project.
Okay, thank you. Very, very good testimony. Members, any questions? All right, thank you very much for your testimony. Chair calls Sarah Pedrati, Transformation Waco, showing for the bill, and Becca Harkle Road is on deck.
Yes.
Did I get that right? Sarah Pedrati? Okay.
Yes.
Transformation World for the bill.
Yes.
Okay.
Good morning. I'm Sarah Pedrati. I am the Executive Director of Student Advocacy for Transformation Waco. Transformation Waco is a nonprofit organization operating in 5 historically low-performing schools in Waco ISD through an 1882 in-district charter. We serve 2,300 students from pre-kindergarten to 8th grade, and 96% of our students are economically disadvantaged. Our turnaround method is based on a community school strategy, which focuses on academics, youth development, family engagement, and support health and social services leading to improved student learning outcomes. Today, I'm going to speak to you regarding 2 different health services that this bill would benefit. First, students in the state of Texas are required to have vision screenings in pre-kindergarten, kindergarten, 1st, 3rd, 5th, and 7th grade. In 2017, in Waco ISD, 70% of our students that had vision screenings failed and needed to see an optometrist for a more comprehensive vision exam. Only 5% of the students actually received follow-up care. Transformation Waco saw a need to provide vision services, and in 2018, we sought funding from a private philanthropic group to pay for a complete vision center. We have used our own funding to pay for a part-time doctor and full-time vision center assistant. A partnership with Essilor Vision allows students to receive free frames and lenses. Our Bernard and Audrey Rappaport Vision Center has served 493 students since its opening in 2019. Our assistant gets between 5 to 7 referrals a week, and our part-time doctor is slated to see 225 students just this school year. We still have about another 30 students who are on a wait list. Being able to bill Medicaid for eligible students would allow us to continue to fund our Vision Center and move our optometrists from part-time to full-time. We'd actually double the number of students we currently see. In 2018, Transformation Waco also created a pipeline for licensed clinical social workers, or LCSWs. These employees treat various mental health conditions, including behavioral disorders, addictions, severe mental illnesses, and serious emotion disturbance. With grants and federal COVID relief funds, we have hired LCSWs to work directly with our students and families. Our model is successful because the social workers are integrated into the school community as staff members. They work closely with our parents and families and provide targeted strategies to our teachers and campus staff. The demand for their work continues to grow as more students experience post-COVID anxiety, depression, drug dependency, and family and community violence. The need outweighs our current capacity for services. However, passing HB 1571 would mean continuing and even expanding these vital services with a sustainable funding source as the grants come to an end. Thank you for considering innovative ways to provide much-needed resources to benefit our most vulnerable students.
Thank you very much. And you may not know this, the services provided in the school, are they also provided outside the school?
No.
They're not available outside the school through Medicaid?
So yes, vision services are. Our parents just are not taking the kids, and we don't have an answer why. So for our vision center services, yes, we have plenty of eye doctors in Waco that will accept Medicaid. The service, just our kids aren't getting there.
Okay, thank you. Members, any other questions? Thank you. Chair calls Becca Harkleroad. And then Hani Talibi is the last person I show want to testify on this bill. I've got you as Rebecca Harkleroad, testifying for self and Texas School Nurses Organization for the bill. Is that correct?
Yes.
All right, thank you. Go ahead.
And way to pronounce it. That was
Well,
great.
you know, working on it.
Good morning. My name is Becca Harkleroad. I'm a nationally certified school nurse and advocacy chair for Texas School Nurses Organization, and I'm speaking in favor of House Bill 1571. You can't educate a kid who isn't healthy, and you can't keep a kid healthy who isn't educated. Former U.S. Surgeon General Jocelyn Elders said those words almost 30 years ago, and they still ring true today. The difference is that the health landscape has shifted, and our kids need the proper tools to our schools need the proper tools to effectively care for our students. So far beyond most people's, including mine, school nurse memories of Band-Aids and ice packs, school nurses now serve as a bridge between a student's health and their education. We promote and protect public health at the school level with education, emergency preparedness, physical screenings, immunization compliance, and disease surveillance. We also provide acute care for sick and injured students, coordinate and provide individualized care for kids with chronic medical conditions, and identify and intervene for those in need of mental health care. As part of the school's team, school nurses help reduce educationally relevant health disparities among students. Research shows that students from economically disadvantaged areas experience more health disparities and to a greater extent than their peers. Particularly in such areas, school nurses are often the first or only healthcare professional that a student may have access to on a routine basis. However, many students in Texas don't have access to a school nurse. In fact, of the 254 counties in our state, more than 10% of those counties did not have a school nurse employed anywhere within the county during the 2020 school year. Most impacted, of course, are our rural areas, specifically in the Panhandle and also down in the Rio Grande Valley. It's very important to emphasize that House Bill 1571 does not aim to expand Medicaid in Texas, and it doesn't increase Medicaid eligibility for Texas students. It would definitely allow our cash-strapped school districts to access federal matching dollars for services that they either are or could be providing for their Medicaid-enrolled students. As was mentioned, it would not require any additional funds from the state, as the initial funds are already put forward by the schools themselves. To date, 17 other states have already made this move, including Florida and, as we heard, Louisiana. When Florida passed the bill in 2020, they projected that they would bring in at least $51 million to their schools, specifically in behavioral health services. Texas School Nurses Organization believes that taking advantage of these available federal funds is a budget-neutral incentive for Texas schools to ensure more students receive the care they need to be healthy, safe, and ready to learn and live to their fullest potential. Thank you for your time. I'm here to answer questions.
Thank you. Members, any questions? Okay. What is done, because you represent the whole organization of the school nurses?
School nurses, yes, sir.
Right. What is done to engage parents? One of my concerns, quite honest, is want to provide services for kids, but the more services we provide, the less engaged we get parents, right? So like, you know, I use this example all the time, like 5% of kids or so were showing up without eating. So now somehow, these years later, now we're feeding 100% of the kids and saying, forget the family table. Kind of the same thing with the nursing. It's like, okay, well, some kids aren't getting to the doctor, so now we're going to make it really, really convenient to make sure that you don't take your kid. So I'm curious, but also want those kids taken care of, right? So I'm not, right? But I'm asking, I was trying to set a little background. So what are we doing as organizations to make sure that parents are actually engaged, both informed and engaged in their kids' health? Because, so I'll.
Yeah, no, actually, that's a really good question. And I can tell you that in schools where there is a school nurse, one of the big things that school nurses do is work on family engagement. Like I said, we coordinate care a lot of times for students, where, you know, we can point out something that the family may not ever realize is an issue or could potentially be an issue, and we can help provide those resources to families in the community. The problem right now is that so many of our schools don't even have a school nurse to do that kind of stuff. So while, you know, somebody may not feel good and they go to the school secretary, they call mom comes and picks them up, they're done. They do that a number of times, and the secretary thinks, golly, this kid's just going home all the time. Whereas the school nurse would think, oh, they have this symptom, and this symptom. These all seem to be really relevant to a chronic condition. We should call the parents and ask them more information and encourage them to take their family to the physician and help provide those resources. So in our, like I said, specifically our rural areas and some of our underserved communities, not having a school nurse just means not having better health outcomes for those people. Most of the time, in those areas, there's not somebody who's keeping an eye on those kids in that way.
There's not somebody, meaning there's not the nurse.
Right. There's not a school nurse who can connect the dots on things like that. Or, you know, I have a nurse in our school district who has a second grade kid who had these chronic stomach aches every so often, every couple weeks. Well, it actually related back to a physical manifestation of anxiety when the kid was going to the other parent's house that weekend.
Right.
So that's not something that an untrained eye would pick up on. Does that make sense?
Sure.
Okay.
Absolutely. All right, thanks. Members, any other questions? Yes, Representative Manuel.
Hello. I have one quick question for sure. How hard is this to implement into the ISDs?
Oh, yeah, another great question. So a lot of our school districts are already billing SHARs for their students who are in special education and have it written into their individualized education plan. So it wouldn't really take much of anything to just shift and not necessarily do these individual billing pieces. Specifically, there's a thing called a random moment in time study, an RMTS, and that's where they look at certain pieces of a day for certain providers, and basically I don't know the formularies or the equations or how any of that works, but I know that's how the funding is usually parsed out.
Okay, thank you so much.
Sure.
Okay. Thank you. Members, any other questions? All right, thank you. Chair calls Haney Talibi. Sure, I missed that one, didn't I? with the Meadows Mental Health, the Meadows Mental Health Policy Institute for the bill. Is that correct?
That is correct. I'm Dr. Hani Talebi. I'm representing the Meadows Mental Health Policy Institute here in support of HB 1571.
Thank you.
All right. Good morning, everybody. Thanks for the opportunity. I'm a duly licensed psychologist and school psychologist in Texas. I've historically served as the Director of Psychological Services at Del Valley Independent School District, as well as the Director of Pediatric Psychology at Dell Children's Medical Center. I'm currently the Chief Clinical Officer at the Meadows Institute, an independent, nonpartisan, data-driven policy guidance organization working to ensure all Texans can receive effective and efficient behavioral health care. I'm honored today to be able to provide testimony in support of policy related to the School Health and Related Services, or SHARS program. As we've heard, the SHARS program allows school districts to obtain federal reimbursement for certain health-related services provided to Medicaid-eligible students. Texas policy currently limits reimbursement to only students with disabilities that possess individualized education plans, or IEPs, through special education. Services covered by SHARS, which must be medically necessary and always provided with parental consent, include both physical and mental health services. Parents and educators alike understand that our students cannot make appropriate academic progress when they are not well. Even before COVID-19, mental illness among America's youth was already at a crisis point. The pandemic, we know, has made it much worse. A CDC survey on youth mental health found 37% of high school students reported poor mental health during the pandemic, and 44% reported they persistently felt sad or hopeless during the past school year. Schools know this and have been managing the significant and negative impact on kids' ability to learn and achieve in the classroom. Of note, half of all lifetime mental health conditions manifest by age 14 and 75% by the age of 24. Without a doubt, mental health conditions are a pediatric issue. Congress established the Elementary and Secondary School Emergency Relief, or ESSER Fund, and provided states and school districts with an infusion of federal dollars. ESSER funds were used to provide access to critical mental health services and address increased need. Often referred to as the ESSER cliff, this emergency federal funding will expire in September 2024, yet the mental health impacts from COVID-19 will last years beyond the pandemic. But federal policy provides an option to address this issue. Since 2014, the Centers for Medicare and Medicaid Services has allowed school districts to offer reimbursement through the SHARS program for covered services provided to all Medicaid-enrolled students, not just those with IEPs. Allowing districts to seek federal reimbursement for covered services provided to all Medicaid-enrolled students would mean schools could continue offering these services to students using local funds as the non-federal match at no cost to the state. Neighboring states, as we've heard, and those with robust Medicaid managed care programs like Florida, Louisiana, and Arizona have updated state policy to align with CMS guidance. Texas has the opportunity to do the same to mitigate the end of ESSER funding. How do we do this responsibly through HB 1571? The Texas way. Parental consent would still be required for any services, could be revoked at any time. Participation remains optional for school districts. Adopting this policy does not expand eligibility or add new benefits to Medicaid. Notification would be sent to the PCP and health plan and families, strengthening the coordination between historically siloed schools, students' families, and students' medical homes. And the state is not required to provide any match to obtain federal reimbursement. Ultimately, leveraging federal reimbursement through SHARS to public schools for vital student services they've already been providing for free means additional resources could be redirected where they're needed most. Academics for students and mental health well-being. Thanks for the opportunity to testify. Happy to answer any questions.
Yeah, thank you very much for that. Members, any questions? I do have a couple.
Please.
Do you see, so you look at policy around the country.
Correct.
Do you see most of the nursing and mental health professionals employees of the school district or employed by, say, the local LMH? I know they're different in different states, but it always concerns me. To me, we're asking schools to do so many things. Like you got to be a restaurant now, you got to be mental health, you got to be, and it's one thing to provide services. You got to be a police department too, by the way.
Sure.
And our people running them, including the school boards, are not trained in any of those areas, right? And yet they're running police departments, mental health departments, everything like that. Do you see some places where the mental health is basically run by somebody else but in the school? I'm not saying it shouldn't be in the school.
Sure.
But I just feel like we're asking the schools to run cities now. So anyway, I was
Yeah,
curious
I
whether it's
love that
done other
statement.
places.
Yeah, the analogy that we use oftentimes is you're taking teachers as if they were Michelin-rated chefs and saying, "Hey, can you farm? Oh, also, can you drive the food trucks and can you run logistics and can do that?" So it is very challenging. There's quite a bit of heterogeneity across the country insofar as who's doing the work. Are they school and district employed, or are they community employed and coming in to do that? I think the communities dictate what the needs are. The resources that they have available dictate what they can and can't do.
I was just curious, best practices, because you mentioned all the statistics and things like that. I think it would be a worthy thing. I know you guys study these issues all the time. It would be a very worthy thing to study, to me, to what is the best way to set this up.
Yeah.
Because I do think people are, I think they're going where the money is, not necessarily what's the best practice on how to do it.
I would offer that trying to approach this from a binary, there's one good way and all the rest are not so good. There are best practices, but they are really dependent on the community. We cannot compare Dallas-Fort Worth with Presidio, for example. They have different needs. They have different personnel and staffing bandwidth and capacities for those types of things. Sometimes they lean on the community. Sometimes they're able to hire from within the community and bring them onto the district. What I would offer is being able to use federal funding to be able to support whatever those services are and not take kids out of school to get those services in the community. They don't have to miss math, science, English classes to go out in the community and receive those services. And the schools are already providing them, to your point. Why not let the schools get reimbursed and put those funds back into their operating budgets through the federal government?
Okay, thank you. Members, any other questions? Thank you.
Thank you.
For testimony. At this time, there's no other witnesses signed up to testify. Is anyone else wishing to testify except that Chair Rose has
I have a
question
question for HHSC.
Okay. Could we get the resource witness, Michelle Irwin from HHSC, on the bill? I know we had two on this one, but I'm hoping I called the right one. So
Sure. If
state
I
your
need
name.
to phone a friend, I can.
Yeah.
Michelle Irwin from HHSC's Medicaid and CHIP Services Policy Team. I am on the bill. Thank you.
Thank you.
Thank you. I'm looking here, it says in the fiscal note that it cannot be determined, but I'm kind of confused because I thought the resources were going to come from local sources and it was going to be matched with, and they were going to be matched with federal funds. So why do you all indicate?
Sure. No, that's a great question. Thank
Can
you,
be
Representative Rose.
determined.
Well, there are multiple ways that this bill could be implemented. One could be in sort of our traditional Medicaid model where we would need to use general revenue funds. So that was one consideration. And then the other is, as some of the witnesses have testified through SHARS, we were also trying to consider that the local education funds would need to be available and potentially allocated as well. And in terms of not being able to determine how much would be needed, we're unsure how many schools would take this up, how many schools would need to bill for services, that kind of thing.
Okay. All right, thank you.
Thank you, members. Any other questions of the resource? All right. Thank you very much. All right. At this time, there are no other witnesses signed up to testify. Is there anyone else wishing to testify on for or against House Bill 1571? Seeing none, public testimony is now closed, and the chair recognizes Representative Lozano to close on House Bill 1571.
Thank you, Chairman Frank and members. This is obviously not reinventing the wheel. Already 17 other states do this. As the gentlelady from Louisiana testified, she's able to hire an incredible amount of mental health providers for a small student population, which is honestly something that we dream of in Texas. We obviously have a youth mental health crisis. It's not a question. It's only worsening. It's only worsening to the point where states are passing legislation to shut down social media companies. But that entire cohort of students that has already been impacted by, if it is social media, their anxiety, their depression, their suicidal ideations, which are increasing at astronomical rates. We have to also provide the funds for our schools. Schools are the best place at this time because everything that's been done now has not been working. We have not been chipping away at the mental health crisis. It's been increasing. And it's our job. It's our job to provide our schools with the funds. And if it's drawing down federal funds, this is incredible. This legislation is no cost to the state, requires parental consent. It's optional to school districts. It's taken a giant whack at the youth mental health crisis. The White House has, as recently as March 1st, 2022, made this a priority. As was mentioned earlier, the ESSER funds expiration is looming. Schools have already seen with ESSER a 65% increase in social workers, a 17% increase in counselors. To help schools sustain these roles, this is from the White House on March 1st, 2022. The Department of Health and Human Services will make it easier for school-based mental health professionals to seek reimbursement from Medicaid. In a memo from 1 month later, April 22, the Department of Health and Human Services, CMS, entitled Information on School-Based Services in Medicaid, Funding, Documentation, and Expanding Services. CMS encourages states to promote the use of schools as a setting in which to provide Medicaid-enrolled children and adolescents with medically necessary Medicaid-covered services, and encourages the state to submit state plan amendments to address these growing needs. The National Association of School Psychologists, schools are an ideal place to provide mental and behavioral health services to youth and children. Schools provide an ideal context for prevention, intervention, positive development, and communication between schools and families. Schools also offer caring relationships and regular, consistent connections between students and staff. School-employed mental health professionals know the students, parents, and staff, which contributes to the accessibility of services. In some cases, like in my house district, in rural areas in Texas, schools provide the only mental health services in the community. My dad has been practicing primary care medicine since 1982. In a very rural part of Texas, he sees like 70 patients a day by himself. He can't get other doctors to move there to help him because no one wants to live in the rural parts of Texas. And he told me ever since I was little that he wishes he could get more LPCs, more psychologists to the area, because all he can do in 5 minutes or 8 or 4 minutes with a patient is write a script. And they need counseling. They need rehabilitative services. And the kids spending from 8 to 3 in school all day, the majority of our kids in our public school system are from needy families. The majority. They're not going home to a parent that has a very good paying job. They're going home to parents that are working 2 or 3 jobs, that don't have the mental strength to play with them because they're beat up from working 60, 70 hours a week. And so if that school can provide them this basic service, I mean, we passed a bill in 2019 that added audiology to this SHARS program. We added audiology. Let's test your hearing. But we possibly might not add mental health. This is the crisis. This must pass, members, and I beg you, from the bottom of my heart, please help this bill become law. Thank you.
Thank you. If there's no objection, House Bill 1571 will be left pending. Is there objection? Chair hears none, and House Bill 1571 is left pending without objection. The chair lays out HCR 37 and recognizes Representative Wu to explain his bill.
Is that gardening accident?
You all right there?
My old man pains.
The gardening accident still got you, huh?
Oh. This is a lesson about using a back brace after you turn 40.
What's that?
Thank you so much. I'm going to keep this very short and very simple. The legislature, in fact, Chairman Frank and Vice Chair Rose, you all passed legislation directing that CPS and the state provide many services for our foster youth, and including provision of IDs, birth certificates, and many other types of documents and services. They're being done, but we're still like having a big catch up to do. They're still not being done probably like fast enough. And we're working with many agencies, including like DISHES and DPS, to try to expedite some of these things and try to work them together. In fact, as a bit of good news, we've been working with DPS to do regional foster youth ID days where caseworkers can submit their applications for their kids who are required by law to get IDs, and DPS works with them and gets all their stuff processed, and they all come just on one day, schedule it, they're in and out like 20 minutes. And so that makes life easier on the caseworkers. It certainly makes life easier on the kids who you know, there's enough stress in their lives. All we're doing with this bill or this resolution is creating a foster youth empowerment day. One, to honor and recognize all the foster youth that we have in our state, many of whom have gone through unbelievable hardships to be where they are, and to, you know, and I'm saying this in a nice way, to survive, right? To make it into adulthood, and which is not easy, as I'm sure as many of y'all know, to be in the foster care system. And not only recognize their efforts, to honor them, but I think more importantly, this will be a day to remind our state and remind our state agencies, hey, we have foster youth out there who are by law required to receive services, or by law required to get their IDs, get their documents, get their training, all these things. And we just want this day to be a reminder to our government, to us, that there are kids out there that need our help and need provisions, need things provided for them, and especially since we passed the laws to require it, to get on the ball, right? And we're really hoping that we can use this day, like, for example, for colleges, to say, hey, we need to go reach out to foster youth to make sure they attend college. For our state agencies to remind, oh yes, we need to make sure that we have policies in place that we get these done and get these done quickly. That's it. It costs the state nothing, and it's a good reminder for the public of that we should take care of our foster youth.
Okay, thank you very much. Members, any questions? All right, yes, Representative Emanuel.
I'd just like to know where you get that back brace, because I'm getting close to 40.
I'll order 2 from Amazon.
I was just going to say, I do like the empowerment part of it, because I think while we want to provide services, these are not helpless kids. These are kids we want to help, but they also have been strengthened by some of the things they come through, and I think there's a balance between providing those services, but also saying, hey, you know, in some cases you've made it. So,
and I think that's a very important point, is that that our foster youth need to know that we see them, right? They have to know that they have people behind them that are rooting for them and that want them to be successful. And I think, you know, a lot of the youth that I've talked to sometimes feel like they're all alone, that no one's watching their back. You know, I know a state day, you know, it means, you know, we know exactly how much that means, but we want to make sure that they are recognized at least one day.
okay, very good. I show nobody else. There's a number of people. Is that? Can you click that up? Okay. At this time, there's no one else wishing to sign up to testify. Is there anyone else or anyone who wants to testify on, for, or against HCR 37? Seeing none, public testimony is closed, and the chair recognizes Representative Wu to close on HCR 37.
Thank you, and on pain of death from Tony Rose, I will close.
If there's no objection, HCR 37 will be left pending. Is there objection, including from Tony Rose? The chair hears none, and HCR 37 is left pending without objection. The chair lays out House Bill 1230, and just this will be the last bill that we hear before going to the floor. You got 2, so you're going to hear them after the floor. The chair lays out House Bill 1238 and recognizes Representative Van Deaver to explain his bill. The chair offers a committee substitute for House Bill 1238.
Ready?
Yep.
Okay. Thank you, Mr. Chairman. House Bill 1238 is trying to make improvements to the way we administer our SHARS program. SHARS, as you all know, is School Health and Related Services. They can provide reimbursement for counseling, psychological, audiological, occupational, physical and speech therapy, school health services, personal care services, and special transportation services. What this bill does is it simply creates a SHARS-specific advisory council at HHSC, which we do not have currently. It sets a specific date for the SHARS manual to be released, to have it released to the schools before school begins, which has been problematic. The manual has been being released sometime in October, typically, after school has begun and budgets are already in place and everything. And then it makes amendments to the SHARS manual subject to the rulemaking process, clarifies the parental consent by adopting federal standards for parental consent, and the goal is to eliminate redundancy in having parental consent signatures. And with that, it's a very simple bill. I'll be happy to try to answer any questions or would like to reserve the right to close.
Members, are there any questions for Representative Van Dever? All right, we will begin public testimony. There are a few people wishing to testify. Chair calls Linda Litzinger, registered for self, and Texas Parent to Parent for the bill. And Amy Litzinger is on deck. Did I get that right, Linda Litzinger?
Yes.
Parent to Parent for the bill.
Yes, for the bill. Thank you very much, Chairman Frank and committee. We're Texas Parent to Parent. Again, we serve every type of disability across Texas in mental health need, and we are for the bill. This committee is very much needed. We're so happy that Representative Van Dever has created this. I will say this, a few years ago, billing companies started calling on schools and saying, did you know that all the billing that you bill for SHARS will be reimbursed to you as GR funds, and you can use them anywhere in the school, not just special ed or wherever they came from, nursing services. So, and they said, we will bill for you. We're very good at billing it, and all we require is 1% of the billing, but you'll be very happy with it. And so there seems to be an unlimited amount of SHARS funds, and it really increased. And that's when the parents started seeing whole paraprofessionals charged to their private insurance when their child didn't have a paraprofessional. In fact, their high schooler changed classes every hour, and so that person would have been in every one of their classes. So, so we have a situation where we have children in a school that very much need the services, and they're beautiful services and they should be served. But this committee is needed to get a handle on how this billing is happening and to give parents an EOB, because actually if we're worried about Medicaid fraud, the parent is the best way to police that. And so please do put 2 parents on this committee, like you said, but I ask you to take one of those parents and require that they also have private insurance too. And because that's what's happening. These bills are hitting private insurance, and they don't even say that it was happened in a school, which then allows the private insurance to deny it.
Okay.
Any questions?
Thank you. Members, any questions?
Thank you.
All right, thank you. Chair calls Amy Litzinger, self for the bill, and then I've got Brenda Oates on deck.
My name is Amy Litzinger, and I'm representing myself from Austin, Texas, and I am for the bill. In addition to everything that was just said, as a self-advocate, I too would like for there to be an explanation of benefits because since SHAR's billing might affect the lifetime cap of somebody who is medically fragile, I believe that having an explanation of benefits so that you know exactly where your Medicaid dollars are being spent as a person is very important. And I don't think that these billing companies fully realize the impact of a lifetime cap on a budget when they're trying to take a percentage of the profits and billing for everything they can. So I really just think we need to have clear information and maybe redraw some of the ethics around what we're doing with charge billing and making sure that people are actually getting what they need and what they pay for through this practice. Thank you for your time. May I answer any questions?
Okay, thank you. Tremendous job again. Members, any questions? All right, thank you for being here. Chair calls Brenda Oates, registered for self in Northeast ISD, and then I show Carrie Moore as the only other person wishing to testify on the bill. So I've got you as Brenda Oates, register for self and Northeast ISD for the bill. Is that correct?
Yes, sir, that is.
Okay, thank you.
Thank you.
Go ahead.
Good morning, Mr. Chairman and members of the committee. Thank you for allowing me to visit with you this morning and share our input on House Bill 1238. My name is Brenda Oates, and I currently serve as the Executive Director of Special Education in the Northeast Independent School District in Region 20. Prior to that, I've served in Lavernia ISD, also in Region 20, and in Huntsville ISD in Region 6 in that same capacity. At Northeast ISD, we serve over 8,000 students with disabilities under the special education umbrella and bring in on average $9.5 million annually in SHARS reimbursement. This money allows Northeast ISD to provide medically relevant services and specialized supports to ensure that students have access to a free, appropriate public education. Not only do those reimbursement funds offset the cost of salaries for those service providers providing the Medicaid eligible services, but they also help to provide specialized equipment, materials, and support for staff and students in classroom and extracurricular activities. I'm in support of House Bill 1238 for multiple reasons. I believe the creation of a SHARS advisory committee would bridge the divide that exists between the clinical expectations of a medical program in the school setting by giving educators and parents a voice in what the implementation looks like. Rounding out that perspective by creating an advisory committee that includes input from what the practical implementation looks like day to day in the school setting and the impact on families is critical. Additionally, the House bill is pushing for more policy around parental consent. Over the past 3 years, the SHARS program has run into a great deal of ambiguity in this area. There's been an abundance of opinions, and that has resulted in school districts being fearful of even attempting to secure Medicaid reimbursement for the time, the effort, and the cost that goes into fighting for those dollars that are rightfully there for the school district to pay for the services we provide. Additionally, there's no state match, and so the burden of paying for the services falls on the state and local shoulders, which actually means our taxpayer dollars that come into the district. We are obligated to provide services regardless of whether or not there's Medicaid reimbursement. Medicaid allows us to do it appropriately without reducing the instructional implications for students as well. Northeast is only one district that is affected by this bill. A study completed in 2021 shared that based on discrepancies in parental consent, districts would lose on average 30% annually in SHARS reimbursement. The SHARS program brings in $790 million to 955 school districts in Texas. And if you have this loss of 30%, that means that school districts are reduced $237 million annually in the services they can provide to students without that Medicaid funding. And finally, as a school administrator, I only get so many opportunities to speak to our staff. When we get the rules from Health and Human Services after the fact, It's very difficult to implement the rules by which we're expected to provide services in order to receive reimbursement. This advisory committee and setting a July 1 date to provide the rules to school districts would be so beneficial in our efforts to appropriately and effectively do the job we've been charged with. Do you have any questions for me?
Yeah, do you think, members, any other questions? Yes, Representative Noble. I think you may ask the same thing. I saw your face at the same point.
I'm just curious.
Yes,
I mean, 9.5 million, is that what you said?
Yes, ma'am.
And that's for your ISD? Is
Yes,
that
ma'am.
Your specific ISD. I'm listening to the previous testimony. It makes me curious what checks and balances you have in place to make sure that 9.5 million, and let's face it, it's your tax dollars and mine.
Right.
It's not made up money. What are your checks and balances to make sure that is appropriate and necessary and needed and used services? That's a lot of billing that y'all are doing.
It is a lot of billing, and the primary use of those funds in our district, there was mention earlier that it goes into the general revenue. It does, and then that general revenue funds the salaries of the service providers in addition to the dollars that come in for the local match of our federal funds for special education. So, in other words, we have a maintenance of effort on the special education side where we have to meet a criteria, one of 5 umbrellas, for our state and local expenditures on special education services as a whole. So that is in providing instructional services to students as well as therapies and other things. So that money goes towards instruction as well as staffing to provide the services. The reimbursement comes in to help cover that as it goes into the general fund.
So let me understand. So you're charging for services for an individual child, but am I right? Where the way you're getting reimbursed for services for an individual child,
Yes, ma'am.
but that one staff member might be providing for a lot of different children. Are they getting to? So I'm just trying to picture what it looks like in a classroom. Or in a
therapy
nurse's
session.
office
Yes,
or
ma'am.
whatever, a speech therapist office. If they're doing 3 children at a time, are they billing for all 3 children simultaneously? How does that look?
Not necessarily. If all 3 students are Medicaid eligible, then yes, ma'am. But they also have to document if it's in a group setting or an individual setting. Those speech therapists, and that's a great example, may be serving 3 to 5 students at a time. They are individually documenting every strategy they're using on each of those 5 students, how that student responds to them, the amount of time that was served, and whether or not that service provision was an individual or a group setting. And all of that has to come together in terms of what we submit for billing services. So we are required to document what that looks like.
And are you ever audited for those?
Oh, yes, ma'am.
Okay.
Yes, ma'am.
Thank you so much.
Thank you. Could you explain, members, any other questions? Yes, Representative Manuel.
And how often is it, like every 3 months that you're audited? Is it, what
We
is
go
that?
through a very lengthy process as a district as a whole once a year.
Okay.
We just completed a desk audit where we had to go back and dig through folders to find things that were years old that we have record and documentation of, but that one piece of paper was missing. And so when we work through the audit program, the desk audit, we have to provide that. Now, in a district our size, we have significant checks and balances and audits in place because we have someone in the business office that works on that. When I was in Lavernia and in and in Huntsville ISD, that work went through the special education office, and then we asked for audits through our business office as well, because we know that there's the desk audit and state audits that come forward.
Perfect. Thank you so much.
Yes, sir.
Thank you. You made a comment, I may have misunderstood it, about losing or possibly losing 30% based on the uncertainty of parental consent and
Yes,
tying those together. So could you
Yes, sir.
walk through
So
that again?
we are required to get parental consent one time a year, or once, and then give annual notice to parents, right? So there has been some question about what our consent looks like when parents are giving that consent. School districts are now hesitant to file in some areas because we're getting pushback from the state on what that parental consent looks like, and if it was detailed enough in that statement that we had, all sorts of things that are being audited. So many school districts are just throwing up their hands and saying we just can't do it anymore because the cost of going through this paperwork is significant. I know that one of the people who testified earlier talked about the billing companies and the profit that they're getting. But I can honestly say that what we pay to the agency or to the company that we contract with for billing is less than half of what our own district charges for indirect cost for administering our federal grants.
Okay, thank you.
Yes, sir.
Members, any other questions? All right, thank you. Chair calls Carrie Moore, and that's the last person I'll show. I've got you, Carrie Moore. All right, we will just show them for the bill. At this time, there's no other witnesses signed up to testify. Is there anyone else wishing to testify on, for, or against House Bill 1238? Seeing none, public testimony is closed, and the chair recognizes Representative Van Dever to close on House Bill 1238.
Thank you, Mr. Chairman. Appreciate the opportunity for you to hear this bill. And again, just really trying to streamline and codify the way we're doing this. And it's interesting because this is where two agencies sort of collide. HHSC and TEA both have interest in this. And so I think this really clarifies the process and hopefully will result in more services for more children. So with that, I close.
All right. Thank you very much. The committee substitute is withdrawn, and there's no, and if there's no objection, the bill will be left pending. The chair hears none, and House Bill 1238 is left pending without objection. The chair now moves that the committee stand in recess until final adjournment, recess of the House, or during bill referral if permission is granted. Is there objection? Hearing none, the motion prevails, and the committee stands in recess.